from Microbe TV. This is Infectious Disease Puscast, episode 17, recorded on December 8th, 2022. I will let people know I am recording this from eastern Uganda, from the little town of Jinja, becoming a big town. I am recording outdoors, looking out at the source of the Nile. So if you hear crashing, that's the thunder. It's all good here. But I apologize for any technical difficulty. You see me swatting myself. That's because I'm recording outside and it's at night, which is not a great place to be with Anopheles mosquitoes everywhere. But I'm Daniel Griffin, and joining me today is Sara Dong.
Hi, everyone. I'm Sara. I'm enjoying the pitter patter. It's very relaxing in the background. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. And on to the literature, shall we? I am kicking us off with the viral section. As a reminder, remember to listen to TWIV clinical updates for COVID and monkeypox related information. So I picked a big one that I can't possibly summarize in Puscast, but there's a new publication in JAMA, Antiretroviral Drugs for Treatment and Prevention of HIV Infection in Adults, 2022 recommendations for the International Antiviral Society US panel. So a 2022 update about ART. And most, some of these recommendations are similar. I tried to pull out a couple reminders and things that might be different from the last time that this was published, I think a year or two ago. So initiation of ART is recommended ASAP after diagnosis, ideally within 7 days, including on the same day as diagnosis or at the first clinic visit if the patient is ready and there's no suspicion for concurrent opportunistic infection. There's a little bit of an adjustment in the guidance around initiation of ART and the timing related to opportunistic infections. And most of this language was kind of in there before, but I think just sort of the final listing for this is a little bit adjusted. So active TB without TB meningitis, start ART within 2 weeks of TB medication initiation, particularly if the CD4 is less than 50. For TB meningitis, a reminder about steroids and TB treatment, and then starting ART within 2 weeks. For cryptococcal meningitis, if you are in a location where you have access to close monitoring and supportive care for adverse events, the recommendation is to start ART within 2 to 4 weeks of your antifungal starting. And then those with patients who are ART naive with asymptomatic cryptococcal antigenemia and a negative LP with no evidence of meningitis should start ART immediately. And then another note about starting ART immediately in the setting of a new diagnosis of cancer with some attention to drug-drug interactions. And so for initial therapy, the regimens are similar to what we knew before, although the abacavir containing regimen is off of the sort of initial list. So bictegravir, tenofovir alafenamide, emtricitabine or Biktarvy, dolutegravir with tenofovir lamivudine, dolutegravir lamivudine if the viral load is less than 500,000 copies, and we know that you don't have a Hep B co-infection. And then there's some notes in here about those who are on PrEP to make sure you get genotyping and then start dolutegravir or bictegravir with tenofovir lamivudine. And for those on cabotegravir PrEP, genotype and then begin an INSTI-based regimen. Otherwise, the things that I noticed that, there is a comment on the updated SAPAMO study results that show no statistically significant difference in neural tube defects. So dolutegravir is a recommended agent for most people with HIV, including those during pregnancy, which I think people were using in practice. There's some guidance in there about weight gain and metabolic complications and sort of how often to think about weight and BMI. And then table 4 is a really nice compare and contrast chart thinking about PrEP options. And otherwise, there's a brief section on substance use, COVID, and monkeypox. So, long summary. Most things are similar to what we knew before.
All right. Important stuff, though. So I'm glad you bring that up. It's amazing how far HIV medicine has evolved, right, over the last 30 plus years. So exciting stuff. And bacterial, be sure to listen to This Week in Microbiology, the article Retrospective Study of Outcomes of Short versus Long Duration of Antibiotic Therapy for Residual Osteomyelitis and Surgically Resected Diabetic Foot Infection was recently published in the Journal of Antimicrobial Therapy. Now, this is something we are often called about. A person has diabetes and then develops osteomyelitis requiring an amputation. We then wait for the pathology report and the cultures from the proximal bone specimen. First off, one requires a podiatrist to properly label all specimens, removed bone, and what is the proximal bone margin? Don't call it the clean margin, call it the proximal margin, thank you. The pathologist then needs to be very clear in the path report which specimen has what finding. So in a situation where this is all done correctly, I will say this happens at Plainview, we might get a report that the proximal margin shows no osteomyelitis and the cultures show no growth. This is straightforward in a situation. Maybe short course of oral antibiotics, then a reasonable chance that we have success. Now, what if that proximal margin is sent and stuff starts growing? What is the chance you end up back requiring more amputation or debridement? Here, the investigators looked at treatment with less than 4 weeks versus greater than 4 weeks. Coincidentally, about the time that a midline could stay in with antibiotics, and reported that among 92 patients, 83% male, median age 67, 26 received less than 4 weeks, and 66 received greater than 4 weeks. In the SD, short term group, you can think of the S as short and the L as long. In the SD group, the primary outcome, reamputation or debridement at the same and or contiguous site of amputation at 6 months occurred in 35%, compared with 15 patients, 23% in the LD group. Secondary outcomes, readmission to hospital and or recommencement of antibiotics for DFI, diabetic foot infection, at the same or other contiguous site at 6 months occurred in 46% in the SD group, compared to 27% in the LD group. Adjusted logistic regression analysis showed SD was not significantly associated with primary outcome odds ratio of 1.12 or secondary outcome OR 1.67. Now, interesting, but I agree that this provides background for a larger trial and that this single center retrospective cohort study is not enough for a practice changing just yet.
I have a paper from Nature Communications, Shigella sonnei clone. I realize that I'm not 100% sure I'd say that right. That's just how I read it in my head. With extensive drug resistance associated with waterborne outbreaks in China. And so this is just a reminder about the Shigella genus species that we have. So Shigella dysenteriae, Flexneri boydii, and sonnei. And sonnei is a major contributor to dysenteric diarrhea. There are some prior phylogenetic analyses of the Shigella sonnei, which sort of divides it into 4 lineages. And there are groups within what is called lineage 3 that have been particularly important. And studies of these show that there has been really a globally distributed multi-drug resistant clade of Shigella in lineage 3 that sometimes gets called global lineage 3. And so I've mentioned a paper about some shigellosis cases in the UK, I think this summer on Puscast, which would sort of fall into this group. So this communication reports a phylogenetic group of Shigella with extensive drug resistance that led to 6 waterborne outbreaks in southern China in the years of 2015 to 2020, mostly in pediatric patients. 92% of the patients were under the age of 14. And so these were frequently kindergartens or primary or middle schools. And so it showed a combination of multi-drug resistance with co-resistant to ceftriaxone and azithromycin, reduced fluoroquinolone susceptibility, and even some that are colicin resistant. And so they do talk a little bit about the possible drivers, such as selective pressure from the antibiotic usage in China, climate change, and then horizontally acquired multi-drug resistant determinants or plasmids. So some scary scary stuff, but really really interesting how these all stem back, and I think is a big problem in various locations around the globe.
All right, excellent. The article, Rectal Culture-Based versus Empirical Antibiotic Prophylaxis to Prevent Infectious Complications in Men Undergoing Transrectal Prostate Biopsy, a randomized, non-blinded, multi-center trial published in CID. I think this makes sense. I mean, here the investigators were investigating infections after transrectal prostate biopsy. With ciprofloxacin-resistant rectal flora, they suggest this necessitates the exploration of alternatives to the traditionally standard-used empirical prophylaxis with Cipro. So they compared infectious complication rates after transrectal prostate biopsy using empirical ciprofloxacin prophylaxis versus this culture-based prophylaxis. So in this non-blinded, randomized trial, between April 4th, 2018 and July 30, 2021, they enrolled 1,538 patients from 11 Dutch hospitals undergoing transrectal prostate biopsy. After rectal swab collection, patients were randomized 1-to-1 to receive empirical prophylaxis with oral Cipro, that's a control group, or culture-based prophylaxis, the intervention group. Primary outcome was any infectious complication within 7 days post-biopsy. Secondary outcomes were infectious complications within 30 days and bacteremia and bacteriuria within 7 and 30 days post-biopsy. Are you ready for this, Sara? Infection rates within 7 days post-biopsy were 4.3% in the Cipro group and 2.5% in the intervention group. P-value of 0.08 and not reaching statistical significance. A trend, but we don't talk about those. Ciprofloxacin-resistant bacteria was detected in 15.2%. In the Cipro group, the presence of ciprofloxacin-resistant rectal flora resulted in a 6.2-fold higher risk of early post-biopsy infections. So that's sort of interesting. If you knew ahead of time you had Cipro-resistant bugs, 6-fold higher chance that you're going to end up with a Cipro-resistant infection. Well, lots of criticisms I have here. First, right, we're thinking about, does this affect our practice? I know a lot of our listeners are here in the U.S. So for starters, the Cipro-resistant rate in the Netherlands is only 15%. So really not the right place to do the study. Then the fact that they did a two-sided significance test, and perhaps most importantly, why are they still going through the rectum and not doing transperineal biopsies with the compelling data for a lower infection in that rate group? So, all right, if we have any urologists, feel free to write in and clarify for us.
I have a paper from MMWR, outbreak of Burkholderia stabilis, infections associated with contaminated non-sterile multi-use ultrasound gel, 10 states, May to September of 2021. So this reported on 119 infections in 10 states that were associated with multiple lots of non-sterile ultrasound gel contaminated with this Burkholderia cepacia complex organism. So these were matched by whole genome sequencing, and the investigation revealed frequent use of non-sterile ultrasound gel to help with visualization before or during invasive percutaneous procedures, which then allowed introduction of contaminated ultrasound gel into sterile body sites. 89% of the reported infections were bloodstream infections. There were 14 deaths during hospitalization in which the Burkholderia infection was identified. The cause of death was available in 10 patients and attributed to this specific infection in 2 of those cases. Reminder about using single-use sterile ultrasound gel, but just, regardless of how it's packaged, like making sure that you're using sterile gel for sterile procedures. And I think one of the guidance here is also if you're sort of preparing to do a percutaneous procedure, and making sure that you clean that area off of the prior gel.
The article Factors Associated with Receiving Longer Than Recommended Therapy Among Culture-Negative Pulmonary Tuberculosis Patients was published in Open Forum Infectious Disease. So this study reported that most patients potentially eligible for 4-month therapy, recommended since 2003, were treated with a standard 6-month course. This subset of individuals that are greater than 15 years old with culture-negative pulmonary disease at diagnosis, and then again at 2 months, and who have no baseline cavitary disease and symptomatic or radiographic improvement with no other apparent diagnosis, can be treated with 2 months of RIPE and then 2 months of INH rifampin, with similar outcomes to the 6-month treatment group. Now, I actually think the importance of this article may really be to raise awareness for most clinicians that this is even an option, as this study findings suggest not many providers or DOHs are even aware. All right. The article Seasonality of Healthcare-Associated Stenotrophomonas Multifilia was published in Infection Control and Hospital Epidemiology. I do not know how many of our listeners are aware, but there can be a seasonality to gram-negative bacterial infections. And here the authors reported that from April 1st, 2016 through March 31, 2022, growth of Stenotrophomonas multifilia from clinical specimens at the author's academic medical center were significantly more likely during July through September than during other calendar quarters. All right, so I can start paying attention. When I stop seeing Stenotrophomonas, it's time to put the sailboat away. All right, fungal. The article Rezafungin versus Caspofungin for treatment of candidemia and invasive candidiasis, Restore, a multi-center, double-blind, double-dummy, randomized phase 3 trial was published in The Lancet. So Rezafungin is a next-generation, once-a-week echinocandin in development for the treatment of candidemia and invasive candidiasis and for the prevention of invasive fungal disease caused by Candida, Aspergillus, and Pneumocystis species after blood and marrow transplantation. So the authors here, the investigators, aim to compare the efficacy and safety of intravenous Rezafungin versus intravenous Caspofungin in patients with candidemia and invasive candidiasis. These are the results of this multi-center, double-blind, double-dummy, randomized phase 3 trial done at 66 tertiary care centers in 15 countries. Adults 18 years of age or older with systemic signs and mycological confirmation of candidemia or invasive candidiasis were eligible for inclusion and randomly assigned 1-to-1 to receive intravenous Rezafungin. I'm going to like that name. Once a week, 400 milligrams in week 1, followed by 200 milligrams weekly for a total of 2 to 4 doses, or intravenous Caspofungin, 70 milligrams loading dose on day 1, followed by 15 milligrams daily for no more than 4 weeks. The primary endpoints were global cure, consisting of clinical cure, radiological cure, and mycological eradication at day 14 for the European Medical Agency, and 30-day all-cause mortality for the US FDA. I think they're trying to get approval here. In this study, Rezafungin was non-inferior to Caspofungin for the primary endpoints.
In antimicrobial stewardship and healthcare epi, characteristics of antifungal utilization for hospitalized children in the United States. As many of the ID listeners would know, antifungal prescribing is quite variable. And I'd say that's probably particularly true in pediatrics, where we often have less consensus guidance or data. And so this study took a look at antifungal prescribing data from 32 hospitals that participated in the SHARPS antibiotic resistance prescribing and efficacy among children study, a cross-sectional point prevalence survey. And so among about 35,000 patients, 6% received at least one systemic antifungal. 57% had underlying ONC or BMT diagnosis. 13% were premature, which I think makes sense that most of these are going to be immunocompromised patients or the premature kiddos that we see in the NICU. Some of the other categories that they had assigned were chronic lung disease, GI disease, congenital heart, hematology or sickle cell disease, surgical patients, and solid organ transplant. The most prescribed antifungal was fluconazole, with the most common indication for use being prophylaxis in 64% of the cases. Something else I found interesting, combination antifungal therapy was uncommon. It was about, I think, 4 or 5%, but it was used for nearly a third of the patients receiving targeted treatment. So I think a little bit of insight into how often people are using combination therapy, which I would say is controversial, although people hold very strong opinions about how effective it is. And sort of the take home that we knew was true is that there is significant variability amongst hospitals, but maybe this can start the conversation about thinking about where are places that we can potentially provide some stewardship and thinking about antifungal use.
All right. The article Cutaneous Blastomycosis Presenting as a Non-Healing Wound in the Northeast United States, a case report was published in the International Journal of Lower Extremity Wounds. I don't know if you read that regularly, but I suggest goes along with our theme that these fungi are all over the place. So let me try working on the stem here. So our exam takers picked this one right up. A 61-year-old male who lives outside of the Ohio River Valley presents with an extensive history of wound dehiscence and wound care noncompliance after a bite from a brown recluse spider on the left thigh while on vacation in Cape Cod in September of 2020. Reports no tick bites and does not remember mowing over a rabbit while vacationing in Cape Cod. As we discussed last Puscast, Cape Cod is endemic for blastomycosis, so this is not a case arising outside the endemic area, just outside the area they use in the stems on board questions. Okay, Sarah, it's you now.
My next one is from OFID, Evaluation of the Diagnostic Accuracy and Clinical Utility of Fungal Profile plus Polymerase Chain Reaction Assay in Pulmonary Infections. So these are results from this retrospective analysis taking a look at BAL fluid sent to Viracor for Aspergillus, Mucorales, and or Nocardia PCR. So they had panel or individual assay components. Overall, the results were a little bit disappointing with relatively poor clinical sensitivity for all three PCR assays. And so just to give a little bit more context, the Aspergillus PCR had the highest agreement with diagnostic reference standard. So 31% sensitivity, 97% specificity, 63% positive predictive value, and 90% negative predictive value. So if you think about this in comparison to BAL, Aspergillus galactomannan, that has generally been suggested of a sensitivity of 85 to 90% with a specificity of 90 to 95%. And in the study, no Mucorales or Nocardia infections were identified by the diagnostic reference standard, so we don't have a sensitivity. But the specificity for the Mucorales was 98%, and then for the Nocardia target was 97%. So overall, low case numbers and, a little bit disappointing, but maybe there's still hope with other centers that publish their experience. We actually just recorded a febrile episode not too long ago that is not published yet, but we touched on the use of these fungal PCRs. And I was telling our guests that I don't have much experience sending the specific fungal or mold PCRs, but I often hear about their uses, like clinching the diagnosis when you have those challenging case sessions at ID Week. So it always makes them sound like they're so successful. But we'll see, I think, as we get more information, whether or not these will be a useful tool moving forward.
And let us move on to Parasitic. Be sure to listen to This Week in Parasitism. We have some great episodes coming up. But when I added this article, I felt confident this would be my favorite. So the article, Parasitic Infection Increases Risk-Taking in a Social Intermediate Host Carnivore, was published in the Nature Journal of Communications Biology. So for background, Toxoplasma gondii is a protozoan parasite capable of infecting any warm-blooded species. Infection spreads either through the ingestion of oocysts shed in the environment by a definitive host, so environmentally mediated transmission via water or vegetation, the ingestion of infected tissue cysts in definitive or intermediate hosts, or if the fetus survives infection, vertically through congenital transmission. So Yellowstone National Park, Wyoming, USA, has a diverse carnivore community, including gray wolves and cougars, intermediate and definitive hosts of T. gondii, respectively. Experimental studies have shown that chronic infections, even in healthy individuals, can lead to increased dopamine and testosterone production. These hormone changes can cause increased aggression and risk-taking behaviors, such as increased hyperactive movement, failure to avoid olfactory predatory cues, i.e. seeking out instead of avoiding felid urine, and decreased neophobia, fear of things that are new. Okay. First, they looked at the cougars and found that of the 62 cougars tested for T. gondii, 51.6% were seropositive, confirming the presence of T. gondii in Yellowstone National Park's most abundant definitive host. They then go on to look at lots of behaviors, and I encourage people to read this fantastic open access article and really fun paper. They found that these seropositive wolves had increased risk-taking behaviors, were more likely to head out on their own, and were more likely to become pack leaders than seronegative wolves, with a p-value of 0.001. And this effect increased over time. There's also a nice perspective piece for those that don't want to read the hard science. All right. I also have the article Efficacy and Safety.
I was expecting you to pick that one.
It's so great, isn't it? It's so good.
Yeah.
All right. The article Efficacy and Safety of Acazabarol in patients with human African trypanosomiasis caused by Trypanosoma brucei gambiense, a multi-center, open-label, single-arm phase 2-3 trial was published in the Lancet Infectious Diseases. For those following the developments here, this is a one-dose treatment, and in this study, oral Acazabarol, so remember that, was administered as a single 960 milligram dose. So 3 of those 320 milligram tablets to fasting patients. The primary efficacy endpoint was the success rate of treatment at 18 months in patients with late stage HAT, modified intention to treat. Treatment success rate at 18 months was greater than 95%, similar to the estimated historical success rate for nifurtimox fluorinethine combination therapy of 94%, as well as fexinidazole, the latest treatment recommended by the WHO, which I will mention requires admission to hospital. All right, and this will be, I think, the last one for me. The article, Case Report, Simple Nodular Cutaneous Leishmaniasis Caused by Autochthonous Leishmania Mundinii orientalis in an 18-month-old girl, the first pediatric case in Thailand, and literature review published in the American Journal of Tropical Medicine and Hygiene. There was a recent morning conference at Columbia where there was a discussion about the appearance of different tropical ulcers and how the appearance of, say, a Leishmania ulcer is different from a Buruli ulcer. Now, the horrible Buruli ulcer caused by Mycobacterium ulceran tends to have these undermined borders where one can put a Q-tip in several centimeters, where Leishmania has no undermining and actually heaped up borders. Now, I was fortunate to visit the Buruli Center in Ghana earlier this year. That's what I do on my vacation, and see a large number of these aggressive Buruli ulcers. So yes, the appearance and aggressiveness is very different. But what I like about this article is mainly the pictures of the nodular lesions one can sometimes see in Leishmania as opposed to the Leishmania ulcers. Also adding Leishmaniasis to the differential for skin lesions in Thailand. I will throw in, I got sort of a little bit of advance warning that we would be hearing about these things because Christine Naula, one of the co-hosts of This Week in Parasitism, her husband is a Leishmaniac and has been talking a bit about how there's probably more Leishmania in Thailand than people appreciate.
Is that a real term? Should I be using Leishmania?
Yes, that is a term of affection.
Love it. So our final one is just a miscellaneous one. I have to point out there is a New England Journal of Medicine perspective from everyone's favorite ID physician, Dr. Fauci, who was, reflecting. It's called "It Ain't Over Till It's Over, but It's Never Over: Emerging and Reemerging Infectious Diseases." And so here, Dr. Fauci recounts some of his, his journey in ID. And just for a sense of scope, I highly recommend everyone check out the landmark event timeline that they created for his 4-decade-long tenure as NIAID director. Um, it's really incredible. And for those who are lucky enough to catch him at ID Week, I think a lot of what he wrote in this article sort of echoes some of the things that he said. But I figured I should just take a quote to close us out from Dr. Fauci. If anyone had any doubt about the dynamic nature of infectious diseases, and by extension, the discipline of infectious diseases, our experience over the 4 decades since the recognition of AIDS should have completely dispelled such skepticism. Today, there is no reason to believe that the threat of emerging infections will diminish, since their underlying causes are present and most likely increasing. The emergence of new infections and the reemergence of old ones are largely the result of human interactions with and encroachment on nature. So I think something that it was extra nice to reflect on, because I think a lot of people were disappointed and sort of chattering about the ID fellowship match and the rates that we had. But that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions, so send them to puscast@microbe.tv and consider supporting the science shows of Microbe TV. Go to microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you will find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.
And I will be back in 2 weeks if I don't die of malaria from all these Anopheles mosquito injections.